The following podcast is part of a certified educational activity titled Achieving Next Level HCM Care and Outcomes with Cardiac Myosin Inhibition, from long-term clinical evidence to real-world data. Access the entire activity and complete the post-test at peerview.com/QVF860. Downloadable slides and practice aids are also available.
Thank you for joining bright and early at the beginning of ACC. I'm Milind Desai from the Cleveland Clinic, and along with me is Dr. Owens.
Good morning, everyone. Anjali Owens from University of Pennsylvania.
So we are going to spend the next hour talking all cool things about HCM and all the things that are necessary for us to take care of patients with HCM. Mended Hearts, we would sincerely like to thank them. It is a not-for-profit organization that offers a gift of hope to patients with all kinds of cardiovascular disorders. There are multiple resources available online as well as they are doing a wonderful thing, and we truly, truly appreciate their involvement and partnership. What are the goals today? We will examine the mechanisms involved in cardiac myosin inhibitors and how they impact HCM, recognize which patients benefit, employ shared decision-making to incorporate CMIs into treatment plans, and assess what's coming down the pike in terms of newer indications. So without further ado, I think we should get started. Again, I'm Milind Desai. The step one before we start somebody on treatment is to make sure we know what we are treating, right? So, HCM is a fascinating disease. Basically, this most common presentation is LV hypertrophy, more than 15 millimeters, more than 13 millimeters with a family history of HCM, or in conjunction with a positive genetic test in the absence of something that can explain this level of hypertrophy. And it can go a full spectrum of presentation ranging from normal to apical hypertrophy, mid-cavitary hypertrophy, basal septal hypertrophy or full septal hypertrophy with outflow tract obstruction and without obstruction. And it can progress from one phenotype to the other as patients get older, hypertension creeps in, just life gets to you, I guess. This is an equal opportunity offender, no question about it. All sexes, all races, all ages, in all places. But it is not rare. The prevalence is thought to be about 1 in 500 based on imaging, and it could be as high as 1 in 200 based on additional analyses. Median age is 46 years. So if this is thought to be a genetically inherited disease, the fact that we are waiting till 46 years to make the diagnosis should be a reason enough for us to do more and look further. So 2 cases are missed for every 1 case diagnosed, and potentially this could impact 700,000 to 1 million Americans. And you extrapolate that to the rest of the world, that's a lot of patients. Unfortunately, disparities in treatment occur despite similar prevalence. And the list of potential reasons are, all of us can predict: sex, race, insurance status, location where they live, rural versus urban, hospital size, etc. So, but it is suffice to say, this is a crucial thing to remember. This impacts everybody across the spectrum. When should I suspect HCM? Symptoms: dyspnea, dizziness, syncope, chest discomfort, palpitations. This is like every other patient that walks into your clinic, into your general cardiology clinic. And symptoms may vary from day to day. I like to often say, symptoms in HCM are kind of like my wife's moods. They change from day to day, moment to moment.
Or the weather.
Yeah. Family history, you have to look for autosomal dominant inheritance, unexpected deaths, sudden deaths, heart failure, stroke. And examination, this is the classic, you hear a systolic murmur that increases with maneuvers like Valsalva. You stumble upon an ECG that looks abnormal, arrhythmias, etc. But HCM could be asymptomatic. How do you work this up? Transthoracic echo, a comprehensive transthoracic echo is the primary modality in most patients. It gives you wall thickness, mass, outflow tract gradient, assess mitral valve diastolic function, strain, phenocopies, etc., etc. It is used for screening and follow-up. In majority of a significant proportion of the patients, we do cardiac MRI to look for precise wall thickness measurements as well as myocardial fibrosis and diffuse fibrosis. And it also is used as an alternative to echo if TE is inconclusive. Sometimes surgical planning, intraprocedurally, we end up doing transesophageal echocardiography. We talk about scintigraphy. About 10% of patients with HCM may have amyloid lurking. So this is becoming almost mainstay part of evaluation, especially in elderly patients where you suspect concomitant amyloidosis. So don't forget about that. So I'm going to introduce Jeff. This is a fictitious name, but a real patient. This is actually my patient. Medical history, coronary atherosclerosis, hypertension, patient had hyperaldosteronism, hyperlipidemia. Family history, unremarkable. Blood pressure, when I first saw him in clinic, 100 and so pretty much nothing to write home about. ECG, normal sinus rhythm, first degree AV block. His biggest concern when he showed up to clinic was his high calcium score, but he did good on stress testing. He achieved 9 METs. Chemistry is unremarkable, and these are his medications. So this is the patient we were talking about, metoprolol, losartan, eplerenol, and rosuvastatin. He reports lightheadedness, dizziness with positional changes, ongoing for years, with moderate effort intolerance. And this patient was early on when we instituted our AI ECG algorithm, where every patient who comes to Cleveland Clinic, we put them through an AI ECG algorithm that we have clinically implemented. Basically, this identifies patients for potential follow-up, and clearly this does not replace current standard of care for diagnosis of HCM, but we have been using this clinically in our practice, in broad Cleveland Clinic practice. So look at this ECG. This is most of us, I think it is projecting well. This ECG is normal. This don't look like LVH here. Yet it was flagged as potentially LVH concerning for hypertrophic cardiomyopathy, and this patient was recommended to follow up with cardiology and hypertrophic cardiomyopathy center. The first set of images that were done, baseline echocardiography, does show a 2-centimeter wall thickness. No hypertensive heart disease I've ever seen results in this level of hypertrophy. So based on this, what's the most likely diagnosis? Not all HCM, not all LVH is HCM, and not all HCM is thick walls, okay? And differential diagnosis widens with age. HCM is across the full age spectrum, but you could have hypertensive heart disease, AS, athlete's heart, amyloid, a bunch of phenocopies, mitochondrial disease, etc. So it's not just one size fits all. We have to have a nuanced thought process when we are dealing with a hypertrophic patient. So, visit continues. His AI analyzed ECG received a very high probability for HCM. To me, this ECG does not look like LVH, but it did. That's why I guess well-trained machines may be the future. So he was referred to us. I ended up seeing this patient. And this is his baseline echo. There is maybe some SAM at rest, not much MR, but when you look at Doppler during Valsalva, there is fair bit of posteriorly directed SAM, posteriorly directed MR, and significant systolic anterior motion. This case is, by the way, published now in JACC case reports. This is baseline echo. His gradients are significantly elevated. He has severe LV outflow tract obstruction in the setting of SAM and basal septal hypertrophy. Preserved EF, resting gradient was 29, post-Valsalva increased up to 68 or thereabouts. So we ended up making the diagnosis of obstructive HCM in this patient. That brings us to Dr. Owens, who will try to make a case for what these new medications could be. Anjali.
Excellent, thank you. Good morning, everyone. So let's talk about how the latest published data about new therapies in hypertrophic cardiomyopathy help to guide our decisions. We'll talk about long-term data from clinical trials and also emerging real-world data. So prior to 2023, we did not have guideline recommendations for the use of novel agents like cardiac myosin inhibitors. Prior to that, as you all know, we were dealing with predominantly AV nodal blockers in beta blockers and non-dihydropyridine calcium channel blockers. There was also the use of disopyramide, and that really represented first and second line pharmacologic therapy for HCM. In 2022, we had the FDA approval of the first-in-class cardiac myosin inhibitor, mavacamten, and that's when real-world use of that agent began here in the United States. And shortly thereafter, in 2023, with the ESC guidelines, and in 2024, with the AHA-ACC guidelines, we saw that cardiac myosin inhibition was now included in guideline-recommended care for patients with symptomatic obstructive HCM, like our patient Jeff. Now, importantly, the cardiac myosin inhibitor class does target the underlying disease process, as opposed to those prior agents, the AV nodal blockers, which of course were not designed to treat HCM, where they were designed to treat other disorders and were kind of repurposed because that was the best that we had. We know that patients on those typical AV nodal blockers sometimes have residual symptoms despite their use. They sometimes develop side effects from higher doses of those medications, and that their use was really not based on randomized, controlled clinical trial data. So what do the cardiac myosin inhibitors bring? One, they bring a targeted approach to treating the underlying disease, and that's important. And how do they do that? These are small molecules that are reversible, and they inhibit myosin-actin interaction at the level of the contractile unit or the sarcomere. And so what they really do is modulate contractility. They take a sarcomere that is typically in a hypercontractile state in HCM, and they bring them to more normal contractility, normal relaxation, and hopefully improved energy utilization. So taking a heart that's working inefficiently in a hyperdynamic state and normalizing that. So there are two agents that are furthest along in their path. The first is mavacamten, and the second is aficamten. And we'll talk about both of these agents today and the data supporting their use or utility in HCM. So here's a list of the published phase 3 clinical trials that we have to date. The pivotal trial for mavacamten was the EXPLORER trial, which was MAVA versus placebo. And the second trial for mavacamten, phase 3, was the VALOR trial. This was in a sicker group of individuals, all of whom were candidates for septal reduction therapy. Patients from EXPLORER rolled into the MAVA-LTE study. That's the long-term open-label extension study for mavacamten. It included both patients from the non-obstructive trial, which was MAVERICK, and the obstructive trial, which was EXPLORER. For aficamten, we have the pivotal phase 3, the SEQUOIA-HCM trial that was published very recently, and patients from SEQUOIA rolled into the FOREST-HCM aficamten open label extension. Included in FOREST are patients from the non-obstructive aficamten trial as well. So that's where we are in 2025, and we have additional studies to come that I'll talk about later. So let's look at the latest data that we have on long-term extension, open label use of mavacamten. This is for patients with obstructive symptomatic HCM, going out about 3.5 years. So what we saw is sustained improvement in gradients. So this is a durable response that is out to 180 weeks, both with resting and Valsalva gradient. And you can see there the thresholds for gradient, that we are below the level defining obstruction in aggregate in these patients. So they achieve gradient status less than 30 millimeters of mercury, which is our threshold for saying the patient has obstruction. And the mean LVEF in aggregate remained within normal limits for these patients as they go along. Now, importantly, by mechanism of action, we know that you can have a reduction in LVEF to less than 50%, and that is something that you have to monitor for ongoing in patients who are on cardiac myosin inhibitors. Not only did we have sustained improvement in gradient, you can see that we had a marked response in NYHA functional class, with nearly 80% of patients, between 75 and 80, improving by greater than or equal to 1 NYHA functional class out at week 180. And I'll just call your attention to the LVEF. We can see that it decreased from a hyperdynamic state at baseline, about 74%, which is typical for an obstructive HCM patient, to a normal range of about 64%. So what do we know in terms of safety? Were there any new safety concerns that emerged 3.5 years later? This is, of course, important. This is a novel first-in-class agent, so we need to look at long-term data to understand, are these drugs safe in the long term? And here what we saw was nothing new. So we frequently see in clinical practice a subset of patients who may develop hypertension. Now, some of that may be the acute hemodynamic effects of releasing gradient or improving obstruction. And so we may get better blood flow and a higher blood pressure on that regard, and we may just see hypertension as people age. But what you can see here in the exposure-adjusted incidence rates out to week 60 and then to week 252, that we're seeing lower incidence rates as time goes on. That is also the case for atrial fibrillation. We know that AFib is common in patients with obstructive HCM, occurring in about 30%, 25 to 30% of all patients with HCM, but higher risk in the patients with obstruction. And at baseline, we saw about 14% of patients with AFib, and that incidence rate decreased over time. In addition, ejection fraction decrease, which again is a key safety marker with this class of medications. About 5% of patients at baseline with a drop in ejection fraction, transient. This is reversible, but important to suggest and to see that there is a decreasing incidence rate over time. The other TEAEs, as you can see there, were pretty much non-cardiac. We do see some dizziness in a subset of patients as we initiate this agent. This usually goes away as they get used to the dose. So let's look at freedom from septal reduction therapy. This is long-term data from the VALOR trial. Again, I told you VALOR was the phase 3 of sicker patients, all of whom were candidates for septal reduction therapy. Let's look and see how they did at week 128. So at the beginning of the trial, which is pictured on the left, 100% of the patients were eligible for SRT. And at week 128, you can see that a small proportion, 15%, met the composite endpoint. 7 of them underwent SRT. 1 was still eligible, and the way we define that is by class 3 symptoms and a gradient that remained above 50. And 9, we had a status unevaluable, so we put them in that bucket just in case that they were eligible. We also saw a marked improvement in NYHA functional class. At baseline here, 93% of these patients were class 3-4. So again, a very sick, drug refractory group. And we saw a marked improvement with, 56% or so achieving Class 1 status. Along with that, we saw an improvement in KCCQ scores and really a very nice improvement in biomarkers, including NT-proBNP and troponin, with many patients normalizing their NT-proBNP. Additional data from VALOR on echo showed a favorable impact in strain, both atrial and ventricular strain. So this is new data looking at strain, again, important when we think about long-term cardiac remodeling. What is going to happen to these hearts over time in a medicine that is impacting contractility? And what we saw is that mavacamten improved global longitudinal strain, left atrial volume index, and left atrial strain out to 56 weeks without significant changes in RV function, again, suggesting that there is favorable improvements over time. This is additional safety data that we presented recently in abstract form. This is looking at mavacamten in obstructive HCM across 5 trials over 5 years. So this is the longest term data that we have. And again, it showed that MAVA was well tolerated and that if anything, the adverse events, treatment emergent adverse events, decreased over time. And I'll call your attention again to those important AEs of interest, which are the atrial fibrillation, ejection fraction decrease, and heart failure. And all of those increased over time, thank you, Milind, over the time period out to week 252. So here's what's coming at ACC 25. If you have time to stop by this afternoon, there is the long-term favorable cardiac remodeling data. This is going to be presented from the VALOR-HCM trial by my colleague Melinda Tsai, so be sure to stop by this afternoon. We also have additional data, the sex-based data from the long-term extension of VALOR-HCM. That's going to be presented as a moderated poster. We have long-term data by genotype status. This is a question that a lot of people are asking. Is it only the genotype positive people that respond or everyone that responds? So this is going to be nice data that's going to be presented tomorrow. And also favorable biomarker data from both the EXPLORER cohort and VALOR cohort, so be sure to catch those tomorrow. Next, let's move to the data on SEQUOIA. This is the next-in-class cardiac myosin inhibitor, aficamten. This was data from the pivotal phase 3 trial published in the New England Journal just last year. These are 282 patients with symptomatic obstructive HCM randomized to aficamten or placebo. Again, you can see that they're obstructed at baseline with the typical hyperdynamic ejection fraction in the low to mid 70s. The primary endpoint of this trial was change from baseline to week 24 in peak VO2, and you can see a least squared mean difference of 1.7 mils per kg per minute. Again, this is a remarkable response compared to placebo. In addition to seeing improvement in that primary endpoint, which is function, we also saw improvement in biomarkers with NT-proBNP, pictured on the right. We saw an improvement within 2 weeks of starting the drug that really came down to its nadir about week 8 after titration of the drug and was sustained throughout the treatment period, going back to baseline during the washout, and an improvement in NYHA functional class. And with this drug, we saw between 50 and 60% of patients improve their functional class by at least 1. As a class effect, we again are seeing favorable cardiac remodeling and sustained improvements in LVOT gradients. So here you can see the gradient data, both resting and Valsalva, pictured on the left, and data on LA volume index pictured on the far right. And again, as a safety marker, anytime you're using a drug that can modulate contractility and reduce the ejection fraction, we need to look at that data. And we saw a small drop in ejection fraction as expected for mechanism of action with this drug. Here are the data on PROs, patient-reported outcomes, with KCCQ on the left, and an angina score on the right. This is important because many of our patients with HCM do report chest pain, typical or atypical chest pain, and so this was a new marker of response that was looked at in this trial. Here's data on safety, and again, a favorable safety profile. AFib was balanced between the aficamten group and placebo in this trial. And we saw very little else in terms of worrisome cardiac side effects. There were the standard smattering of palpitations, dyspnea, fatigue, headaches that we see in many trials. And there were 5 patients in SEQUOIA, amounting to 3.5% of the population, who had a transient drop in LVEF to less than 50%. However, none had to interrupt treatment, and none had an exacerbation of heart failure, important to note. So what's coming for new data from SEQUOIA? Here at ACC, we will have today, later this morning, data on understanding the impact of placebo on patient-reported health status. And I didn't call your attention to it, but it is a very important point that we see a significant placebo effect in these trials. And I think it highlights the importance of having a placebo arm in many of these trials because the effect can be significant, 20-30% of people responding on placebo. So we want to understand that further with additional data. We are also going to have data on the effect of aficamten on cardiac structure and function. This will be from the MRI sub-study of SEQUOIA and FOREST. That will be tomorrow, presented by Dr. Masri, and also outcome on withdrawing standard of care therapy, including disopyramide. So that, again, important, that will relate to how are we going to use these agents in the real world. Aficamten is not yet FDA approved, but has a PDUFA date of later this year. So what else is coming that's new and exciting? MAPLE trial should be reading out, we hope, sometime later this year. This is the first head-to-head study of a cardiac myosin inhibitor, in this case aficamten, versus a beta blocker, in this case metoprolol. These are patients, again, with symptomatic obstructive HCM. And this is the kind of study that could potentially move the needle on guidelines. Now remember, even in 2024, our latest set of guidelines suggests that we should start with an AV nodal blocker and then add on a CMI for patients who remain symptomatic and obstructed. But this trial will look at aficamten versus metoprolol with a primary endpoint of peak VO2. So I am going to now turn back to Melinda Tsai to talk to us about how we fine-tune treatment in the CMI era.
Perfect. Thank you. That was a very good, excellent overview of what the trial landscape is, but all of us live and work on the main street, and we gotta understand what happens when the rubber meets the road of the real-world data, right? So let's briefly talk about what these trials have done. So quickly, ACCAHA recognized, and ESC too, and they have given concrete recommendations for managing symptoms. So beta blocker or non-dihydropyridine calcium blockers still remain first line, at least for now. If symptoms persist, then there is equal weight given to myosin inhibitors, disopyramide, or septal reduction therapy after appropriate shared decision making. We are not here to discuss guidelines. These are what the stuff stated in the guidelines. So, mavacamten was approved under the REMS Risk Evaluation Mitigation Strategy Program because of concerns related to LV systolic dysfunction. These are cardiac myosin inhibitors, so they're going to inhibit the cardiac myosin. So we need to make sure, the FDA wanted to make sure that it, in real-world application, things were managed and monitored appropriately. So monitor ejection fraction, do not initiate if EF is less than 55%, interrupt if it is less than 50%. Mavacamten gets excreted through the cytochrome P450 system. And there could be issues with inhibitors as well as inducers in terms of its impact. So it is important to make sure we monitor and check for drug-drug interactions. And since this is a first-in-class new medication, the FDA recommended or mandated that everybody needs to be on the same page. So the providers, the pharmacists, the nurses, the patients, everybody needs to be on the same page, which requires training, et cetera. So what does the real-world data show? This is from the first 22 months of mavacamten initiation. So every United States patient that got mavacamten is included in the database at the time of the cut. So more than 6,000 patients, real-world patients with symptomatic obstructive HCM receiving commercial mavacamten enrolled in the REMS program, of which almost 2,000 got more than 1 year's worth of the drug. So what did the data show? LVEF reduction less than 50% was seen in 4.6% patients. As part of the REMS program, they come ever so often, and every time there is a patient status report form filled out. So out of 29,000 patient status forms filled out, EF drop less than 50% was seen in less than 1%, so 0.9% patients. Heart failure hospitalization, 1.3 patient population percent, 0.3 patient status forms. And the combination of EF drop and heart failure hospitalization was seen in well under 1% patients. So this is real data. This is the world's largest prospective registry in hypertrophic cardiomyopathy, mandated by the FDA. Again, in patients with more than 1 year's worth of treatment, similar, 4% EF reduction, 1.5% heart failure hospitalization, and 0.2% combination, but later resumed treatment. 52,000 drug-drug interactions forms were completed, and 0.25%. So a very small proportion resulted in mavacamten dose reduction, and a third of a percentage resulted in discontinuation of a concurrent medication. So very good-looking real-world experience. Efficacy. 100% met criteria. You cannot get the drug unless you have obstructive HCM, defined as a gradient rest or Valsalva more than 30 millimeters, and presence of symptoms. Okay? More than 50% reduced to less than 20 millimeters of mercury. And as you can see in the tables, excellent response at 3 months as well as 6 months. So, as I alluded to, mavacamten is contraindicated for use with some CYP450 inhibitors and inducers. Moderate, certainly moderate to strong inhibitors or inducers. And what are some of the examples, real-life examples? Obviously, Paxlovid. That's a complicated drug, and it has a complicated relationship with other drugs as well as a lot of people. So it is what it is. So you have to be mindful when you prescribe Paxlovid. The most common drug, at least in our practice, is omeprazole, and we've just resorted to switching to pantoprazole. Fluoxetine and other antidepressants you have to be mindful of and consider switching to other drugs, as well as antifungals like fluconazole. Sometimes dose adjustments are needed when you are using it concomitantly with amiodarone, and probable interactions with alcohol and marijuana. So it is important to get a thorough social history. But I will contend in HCM, with the high likelihood of atrial fibrillation, I tell most, if not all my patients, stop drinking alcohol. That solves a lot of problems in the world. Multidisciplinary collaboration has been used successfully, and this is a team sport between physicians and nurses, nurse practitioners, pharmacists, et cetera. So what is the other real-world experience? I gave you the large-scale data from all over the US. So this is something that we published last year. The first 150 patients who were initiated on mavacamten for symptomatic obstructive HCM at the Cleveland Clinic. Slightly older population compared to the trial population, 83% on beta blockers, so we are treating them appropriately with first-line therapy, and majority of them were class 3, so this is just happens to be our practice profile. And initiated on 5 milligrams as recommended, and basically the outcomes align with clinical trial results, as you can see in terms of EF being preserved, gradients resting in Valsalva remaining or getting obliterated, and significant symptomatic improvement. There's something else. There were a small proportion of patients who said they did not improve while on mavacamten, but the gradients, the mean gradient went from, Valsalva gradient went from 70 to 20 or 30. So they had a significant improvement in the gradients, but they still were concerned about symptoms, which suggests that there may be something else like diastolic dysfunction that may be attributing to that. And in this group, one patient has undergone septal reduction therapy. So they're all being medically managed on mavacamten. Similar data from Dr. Owen's group at University of Pennsylvania, 96 adults with symptomatic obstructive HCM. Again, look at the mean age, similar to our data set in Cleveland. So in real world, these patients are a little older. More than 90% attained complete hemodynamic response by week 36, and the median time was 4 weeks to achieving a complete response. There were 2 patients requiring temporary interruptions. Again, in my data set, 2% patients needed temporary interruptions. Similar, very similar to here. No deaths, MACE, or hospitalization issues. And look at the bar graph on the right. Majority of the patients are managed with the lowest 2 or 3 doses. So this is a very potent drug that works at the lower doses to do its highly effective job. Putting it all together, so that's essentially, this is Jeff, a real-life patient. You know, minding his own business, going for an executive physical for calcium score. AI ECG finds HCM, sends this patient to me. We do the additional workup, we find obstructive HCM, and then we discuss. He was definitely not ready for surgery just yet. So we started him on mavacamten following REMS enrollment and prior authorization. At 4 weeks, his gradient, resting gradient, reduced to 7. 8 weeks, it is down to 9. Fatigue is improved. We are down escalating his beta blocker dose. And we can have a discussion about why I chose to continue losartan in this patient, who, by the way, had hyperaldosteronism. So it was important to treat his underlying disease. So what's next, Dr. Owens?
All right, so here we go. In the last few minutes, we'll talk about what's coming, and then we'll have some time for questions. Another area that's adjacent to HCM, and of course a very large clinical population, is of course HFpEF. And as you all know, treating HFpEF patients, there are some HFpEF subgroups that are similar in traits to HCM. And what I mean by that is you see left ventricular hypertrophy, although usually concentric and not asymmetric. You see left atrial dilation. You see diastolic dysfunction. So there are some similarities in that umbrella between non-obstructive HCM and HFpEF. So this was a very small, open label, kind of proof of concept study looking at low-dose mavacamten, 2.5 milligrams, up to 5 milligrams. And this was looking at 26 weeks, predominantly looking at safety, tolerability, and some early look at biomarkers. So here I have pictured for you the biomarker response in these patients. Troponin, NT-proBNP, both improved. And LVEF, we did have 3 patients who had a transient drop in LVEF to less than 50%, all of whom recovered. So that take-home point, right? This is modulating contractility, and like other drugs that we use, we have to get to the sweet spot. The right target for each patient may vary by the individual. And so you really need to think about how you're modulating contractility. And if you went too far in one direction, you can come back into the other direction. And that's how we are using these drugs. So in summary, and then we're happy to take your questions, so please put some into the chat. We know that HCM affects all people, all ages, all over the world. And a take-home point is that the majority of patients are still undiagnosed. So we have our work cut out for us in finding those patients, just like Jeff, who came with his high calcium score and some nonspecific symptoms, to hone in on the diagnosis of HCM so that we can find those patients using multimodality imaging, perhaps with the addition of AI, and that we now know that we have new targeted treatments, including cardiac myosin inhibitors, which are now recommended by the guidelines. Mavacamten is FDA approved and commercially being used. Aficamten, not yet FDA approved, but with a PDUFA date set for later this year. Real-world data has shown in long-term experience with mavacamten that it is safe, it's well-tolerated, and it's effective. So for your patients who remain symptomatic with obstructive HCM, avoid the inertia of just saying, okay, everything's fine. They don't have to live with symptoms. They can feel better. And in many patients, it's worth the try, as long as they're invested and they're able to come back for safety echoes, they're able to report if they have a new drug that they're trying to check for interactions. All of those things are important. Dr. Desai said there's still patients who remain symptomatic even after their gradients are gone. And how do we attack those symptoms? Of course, we need to look at comorbidities like obesity, diabetes, sleep apnea, but there may also be pathways within HCM that we can target. So I will stop here and we'll take some questions. Thank you for your attention.
Thank you. We have a bunch of questions in the chat, so we can start to address. First question was, is atrial fibrillation almost guaranteed at some point in all these patients, especially if the ones that are uncorrected, even if asymptomatic? So the prevalence of AFib, prevalence and incidence, is pretty darn high. Most observational registries talk about 20 to 30%, and I can contend we are not putting in linked devices in all those registry patients where we have caught everything. So the proportion of patients is pretty darn high. Is it 100%? I don't know. I hope not, but it certainly is high. So this is something we have to keep an eye on. I will say this, the strain data that Anjali showed about LA volume size improvement, strain improvement, my hope and expectation is that if you parlay that into the long run, that would yield benefits in terms of stabilizing or potentially reducing the risk of AFib. And perhaps disease modification early could be the key.
Yeah, I mean, we've all seen those atria that are, the size of your head, and you think, oh my goodness, AFib is coming. Those are patients who we probably need to be monitoring more closely. But if we can make that shift in remodeling to improving left atrial size, I agree. I think that we'll see the data as it comes long term, but that exposure-adjusted incidence rate of AFib, at least from the long-term 5-year data, shows that it is lower. And hopefully that's a trend in the right direction, but certainly something that we have to watch for in all of our patients.
Next question was dosage adjustments of other meds for patients taking CMIs. So again, we have gotten very aggressive. After the first 8 weeks of being on mavacamten clinically, if the patients are doing well, gradients are gone, then we are quickly lowering the beta blocker and the calcium channel blocker doses. We have many patients who are now on monotherapy. A lot of patients come back and say they don't realize that they were feeling bad on the 200 milligrams of Toprol XL. The other thing, and this is again my practice, you may have slightly different, but since the approval of mavacamten, we have not started a single patient on disopyramide. That is definitely not the breakfast of champions. It's got many, many side effects.
I agree. I think this is a moving target and where, it becomes more of an art than a science, but we're going to learn how to use standard of care therapies in conjunction with CMI. And I think if you need them for some other reason, then it's fine to keep a patient on a beta blocker, calcium blocker. But many of our patients don't need those agents once the obstruction and the symptoms are adequately treated by mavacamten. And so we too are now pulling back on those standard of care therapies to see how patients do. And it's an individually based discussion. So we don't have a protocol in place, for example, to say decrease the beta blocker by 50% at week X, but a shared decision-making conversation to say let's reduce. Now, ahead of starting mavacamten, in many of our patients who are on high-dose calcium blocker, I will go ahead and reduce that dose before starting because there can be an interaction between MAVA and the calcium blockers. So I think you can take it either way. If they're on disopyramide and they're coming off, we sometimes do a cross titration where we bring the diso down, start the MAVA, stop the diso. So you can do a number of different things. And again, I don't think there's great data behind it yet.
So there's a couple of questions around the clinical application, real-world applications. I'm going to try to. One is there's a boxed warning for heart failure on the label for mavacamten. Can you still use it for heart failure patient, for your HCM patient who have heart failure? And what's going to happen to the REMS program in terms of echo monitoring? So if your ejection fraction is normal and you have obstructive HCM with symptoms, the symptoms of shortness of breath, that can be labeled as heart failure. These patients are appropriate to start on mavacamten. At this point of time, the REMS program wants us to monitor ejection fraction via echo at frequent intervals based on the real-world evidence that we are showing and continuously showing that the stringentness of echoes to be performed may be eased.
Yeah, I mean, my personal belief is that there is probably a subset of patients who require more close EF monitoring, just like other drugs, where you may have a risk factor that goes into your potential for dropping your EF, and that the majority of patients are not at high risk. But we're hopeful that the majority of patients could be able to space out their echoes. We know that of the thousands and thousands of echoes that have been performed, a very, very small percentage have resulted in a change or a temporary hold of MAVA. So I think that's great real-world data to have, and we'll soon find out. I do think we should try to find those people who are at risk so that we can identify them up front, as we do with any other medication that we use, but we'll see if that data comes.
Yeah. And there was a question about permanent ejection fraction reduction or drop. These drugs, this class of drugs, once you stop the drugs, once they wash out of your system, the ejection fraction recovers, unless, of course, there is something else going on that you had not accounted for. Do you agree?
I agree. And I think there's one other good question we should take, which is a real-world application question. Most of our prior authorizations for mavacamten are being initially denied. Is there a strategy to reduce this administrative burden to our clinical staff and improve patient access? So this is an important question, and I think what's key is when you are writing that office note and you are contemplating starting mavacamten on that patient at that time, it's important to document that they remain symptomatic with high gradients despite maximally tolerated first-line therapies. And explaining that, and that note is the one that goes on to the insurers, et cetera, to get authorization, often will then get rid of the headache of having to do an appeal or write an additional letter, et cetera. And we even put a phrase in if needed from the trial data to say, this was the trial, this was the population, this patient fits it, they are still symptomatic with high gradients, and we would like to try the next in-class medication.
Yeah, I think, guilty as charged. Early on in the commercial experience, I would forget to put NYHA class 2 or 3. I mean, it's in my notes, so interpret it, but they don't like to interpret it. So just specifically put that, and often the insurance company will say, why is this patient not on beta blocker? Okay, we tried this, they had side effects, so then why is he not on calcium channel blockers? And sometimes we gotta do the song and dance. What else? What is the most accurate means of assessing ejection fraction in patients with HCM and small cavity? At this point of time, echo is the first line. CMR is probably more accurate, but unless you can, we just do not have, as a world and a society, the bandwidth to do CMRs that frequently. So AI, I think, is going to play a huge role in the future for a quick assessment. I think we are
out of time, but thank you everyone for joining us early in the morning. Hope you enjoy your ACC experience.
Thank you again for joining. Thanks.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Mended Hearts Incorporated. This activity is supported by an educational grant from Bristol Myers Squibb. To access all materials for this activity, visit peerview.com/QVF860.